Let's see, they were working off a substitute yesterday.
Yeah, the versions are in here, but this is the sub. Same one. 788S.
Alright.
Grab the sign-up sheet.
Alright.
Two people.
Lauren, are you ready?
Yes, sir.
You got anything else you want to say before I open it up to the other side? Good morning, ladies and gentlemen. Good morning. If I could, to remind everybody to cut your phone on silent or cut it off. If not, you'll be using somebody's money to buy lunch for the committee today if it goes off during the meeting. Interrupts. I want to welcome all interested parties here again to the House Regulated Industries Committee. You may remember where we left off yesterday because of the time constraints. We had started on the substitute to House Bill 251, LC 520788S. The author of the bill had made a presentation yesterday to kick this thing off, and I have asked him did he have any more that he wanted to add to that, and he said no, so we're going to turn it over to the other side, and I'm presuming there is another other side to this that want to be heard on this matter. First off, who is representing the other side? Would that be Mr. Jet Tony?
Yes, sir.
All right. I'm going to show a little bit of legislative courtesy to a fellow member, Dr. Newton, Dr. Representative, the Honorable Mark Newton, is an emergency room doc. He's got a 10:30 meeting, so we're going to go ahead and hear from him and to see if he can add a little bit to this confusion. Doc?
I don't want to add to the confusion, sir, but I do come today really representing patients and the team approach that we have in healthcare now. I can tell you I work with dozens of nurse practitioners, PAs, fellow doctors. I work with trauma surgeons, cardiac surgeons, and a lot. I'm an emergency department physician. I've done that for over 20 years. I won't say how many over 20 years, but I've done it a long time. And of course, what I see, I'm going to speak mainly to the fact that this bill really is across the state of Georgia and includes full-service acute care hospitals, but I know it also includes ambulatory surgery centers, smaller hospitals where the risk of the patients may not be as much. If the surgeon feels like the risk is appropriate, they can do them in a surgery center, and those might be different. I'm going to speak mainly to the fact that this bill is so broadly written, it includes all acute care hospitals now. By nature of the way that works now, many of our less acute patients, if they have a low anesthesia risk or a low surgical risk or both, they can be done in an ambulatory surgery center, a smaller rural hospital, something like that. What that's left is for our acute care hospitals is just a generally sicker population than there used to be before there were ASCs. So the patients in a hospital are sicker. What my experience is obviously in emergency medicine and trauma. There isn't a day that goes by that something unexpected turns with the patient. Something's going fine and the child seizes and stops breathing. Somebody else has a cardiac arrest, or maybe we get notified that 2 minutes out someone's bringing in a cardiac arrest, like I know some of our members are in EMS. There's a lot going on when a level 1 trauma or level 2 trauma comes in. They're probably going to end up in the operating room as well, but in the beginning, you're going to have radiology techs, CT techs, you're going to have people working on intubation, people working on maybe does a chest tube need to be done, does this femur fracture need to be fixed, and the staff really need to know who's in charge. A lot of people will be talking, it's very loud, when things go wrong, and I'm just saying these patients come in when things have already gone wrong. it is vital that you know exactly who's in charge. I know one of the members has been in the Navy. I was in the Army. It's good to have a chain of command when things go bad. When everything's going smoothly, there's really not much of a problem. It's kind of a piece of cake. Everything's routine. As the anesthesia providers will say, blood loss has been less than 50 cc's. That's a kind of a joke around every surgeon. They never have any blood loss. But it can be crucial to know who's going on. When I look at line 18 in this and change what currently says, let's see, direction and responsibility. And I would kind of put those are really two ends of a seesaw, if you will. The responsibility, the direction means somebody's got to make the final decision on for example, in that trauma situation, I mentioned 5 different things that we might do first. Go to CT, go to the OR, do a chest tube, stabilize the neck, take a portable x-ray. Somebody needs to make the decision, and the staff deserve to know who makes the decision, and even more important, the patients and their family deserve to know that there's one person in charge. And some teaching hospitals go as far as to have a particular color construction hat or baseball hat so that the staff know, I've heard 2 different orders, which one do I do? And you go to the person who's clearly in charge. And by the way, this isn't a male or female. More anesthesiologists are female now than male. That's the people who do 4 years of college, 4 years of medical school, and 4 years of anesthesia, about 16,000 hours of supervised clinical training. In the current situation, the anesthesiology doctor is clearly in charge. If there's 2 people that do a certain amount of anesthesia, one's a nurse anesthetist and one's a anesthesia physician. Our current situation works well in that situation. You get to use the team approach. Medicare, for example, allows one anesthesiologist, as long as they're board certified and they're in the operating room, they can have 4 cases going with very highly skilled nurse anesthetists, and as long as they're available. They can't have their own case going, by the way, because they could never leave it. So they can't have a case of their own and supervise 2 others. That wouldn't be allowed. They have to be immediately available. And these situations, obviously, in the OR are more rare than what I talk about in a daily expectation in the ER multiple times a day when things have gone shockingly, surprisingly wrong in some area or arriving. But they do happen in an operating room. And I just think that with our patients who count on us, they count on their surgeon and their other physicians to make a decision. I think having a clear recognition, especially in an acute care hospital, is vital to the patients. And I really think that's a danger of this bill, is to introduce confusion of some ill-defined coordination that's supposed to, every now and then 2 of us disagree. If I'm not the attending, I just make a suggestion to the attending in the room where I came in to help with a cardiac arrest or seizure, for example. We know that this woman over here is the attending, and she makes the decision on what the nurses do next, because it's her patient. The coordination, I think, would introduce something. I think that direction and responsibility are maybe 2 sides of a coin that need to go together, and right now that's under a team leader that's a physician, and I think that's the way it's the safest for patients in Georgia. And frankly, better for the staff in a critical situation. That's all I have, Mr. Chairman, members of the committee. Obviously, I see a different slice of critical care patients than some simpler operations or lower risk operations going on in an OR. But it is vital, and I think that to change this from direction and responsibility would be a step back for patients. So thank you for the opportunity to go first so I can.
All right, let's see if we have any questions for you, Doc.
Sure.
Committee, any questions? Number 12, Chairman Jaspers.
Thank you, Chairman. I just want to reiterate, I think you and I echoed the same thing, and I echoed yesterday, and you were in the committee somewhere else, about leadership in the hospital, in the emergency room, wherever it might be. And I'm just glad you came today to reinforce that. Thank you.
Thank you, sir.
If I might ask a question, when you talk about direction and supervision, are you talking about by an anesthesiologist or by the chief? And I'm only presuming that would be the surgeon or whoever's in charge.
Well, most of my experience obviously is in a hospital where there's always an anesthesiologist supervising some wonderful, very skilled CRNAs. I do know, and a family member of mine's had a hip replacement at a surgery center. She did have an anesthesiologist doing her anesthesia, but I know for less less acute or risky patients, they might have a CRNA. But the surgeon kind of makes that decision on, number one, on whether they should be done in the hospital or safe to be done at a surgery center. I like the fact that the surgeon has, in the current law, separate from the hospital, does have the responsibility for both the risk of anesthesia to my wife, for example, and the risk of a technical problem during surgery. Because right now they've got that direction and responsibility that are two sides of the coin. That surgeon has to think about both and can't just order the nurse anesthetist to do, well, I mean, they're responsible for the risk level of patients that's done in an ASC, a surgery center. And so I kind of, you know, for one family member of a patient, I like the fact that the surgeon has some risk involved, if you will, skin in the game, whatever you want to call it, to where they may be under the direction to make sure they hire great anesthesia, that they understand enough to supervise. They're very careful about only having lower risk patients in their surgery center because they're responsible for the anesthesia risk as well as the technical risk of the surgical procedure itself. So I think that direction and responsibility that's in the current law, that are two sides of a coin, are important to really have in a single individual. And I don't think anybody would argue that the training, the 16,000 hours of supervised, not job shadowing, not doing orders like you might do on the job training, that's 16,000 hours of supervised clinical training. Learning how to be a physician and be the one giving orders, not just doing the orders. I think it's important that that be the anesthesiologist.
I want to be sure I'm understanding right, because this is somewhat new ground for me, but I was always under the impression that in an operating room, that surgeon would be in charge. They would have the final say about the care and treatment of that patient.
They do have the final say under the current rules.
Because I'm one that believes water runs downhill. We heard the comments yesterday, example of the Navy, that on the aircraft carrier they have an anesthesiologist, and maybe on the lesser ships or whatever they might have an anesthetist. Well, we all know that admirals are going to get the first level of service, but
Comes with a lot of responsibility too,
Yeah.
as you know.
But I'm just curious. In a lot of these cases, or what you say, the smaller facilities like the AmSurg centers and places like that, that the doctor and anesthesiologist, or excuse me, an anesthetist, might work under the supervision as long as it's clearly written and understood that that doctor has the say.
Has the final say.
They can work in cooperation with that anesthetist, but they're
The nursing staff and the advanced practice nurses, which CRNAs are a version, those are vital team members that bring vital information. We work together as a team, and the way it now is, there is a point at which, though, when a decision has to be made that, and you're right, the surgeon in that particular case or the physician does have the final say. If there's disagreement in the room as to what to do next, the surgeon does have the final say in those outpatient. Those are lower risk situations. They're not my main concern, but certainly patients do care about the risk there too.
And I think probably a lot of that's got to do with my observations is when us normal folks, when we have the option to pick a surgeon, we pick our surgeons. We don't necessarily pick the anesthesiologist or the anesthetist. So we have more confidence in whoever that doctor might be or that surgeon.
And it's good for that surgeon to care about the whole nature of your care, from the time they put you to sleep to during the time the surgery's being done and waking you up safely at the end. The way it now stands, that surgeon does have that responsibility, and in particular if they're going to do it outside of a fully staffed hospital, whether in a rural area or an ASC, they have to think about the entirety of that risk. And so it's pretty valuable to have them on the responsibility side of that coin for that. So
in the current situation, somebody's having surgery, you have a surgeon, but you have an anesthesiologist. Who has the say? One or both, or?
That one, there is a joint effort in the same way when I work with a trauma surgeon or a general surgeon on an appendectomy or whatever. There are pretty clearly defined roles among equally trained and board certified, cardiology. We all know where the lines are between the specialties, and you're right, the anesthesia physician would have the anesthesiologist would have the hierarchy, if you will, on the expertise on anesthesia production over the surgeon. But that's because of the nature of how training works with postgraduate, not just post-undergraduate, but post-medical school and then residency for 4 or 5 years. That's
More of a cooperative effort.
it is. It is.
But a surgeon could terminate the surgery if there seems to be some kind of case.
Oh, sure.
To tell the
Certainly.
anesthesiologist, I don't feel good about this, let's pull him back out of it.
Absolutely. That does that.
All right. You have a couple of questions. Number 16, that would be,
That's actually me, Mr. Chairman. I don't know if my the light's not lighting up, but I'd just like to make a comment. 2 years ago, I had a knee replacement. I was in the hall on the gurney with an IV going into surgery, and the anesthesiologist walked out and said, "I'm not going to do you outpatient. I want you to have an art line." Art line is a procedure where they put a receiver directly into the artery to monitor your heart. I had some, before this fall, I had an aortic stenosis till I got a new valve. So there are no set rules. Anesthesiologists do override the surgeon. Obviously, when the anesthesiologist says, "I'm not going to do this patient here. This is a dangerous procedure for this patient." I've been looking at his records and see this. So it's very vital in patient survival for an anesthesiologist to be overlooking a surgeon, and he can make the call to cancel the surgery. They cancel my surgery, so it happens. Thank you.
And that was to put you in a safer place.
Yeah.
Well,
let's see, had somebody else down there. Number 10, did you want to back off or
Yeah, that's fine.
no question? All right, any other questions for our colleague? Thanks for
thank you
taking
for
time,
the
Doc.
opportunity, Mr. Chairman. Thank you,
And I hate
committee.
to tell you, but I got you 5 minutes to spare to get to your budget meeting. All right. All right, next up, to the other side, who's gonna be the general, who's gonna be the admiral marshaling the troops on this?
Good morning, Mr. Chairman, members of the committee.
Jet Tony, representing the Georgia Society of Anesthesiologists, organization whose mission is to provide world-class continuing education for anesthesia providers, including anesthesiologists, anesthesiologist assistants, and certified registered nurse anesthetists. The other part of the mission of that organization is to work hard to assure that public policy protects patients. And anesthesiologists and the anesthesia care team members are the advocates for patients when surgeons are doing what surgeons do and manipulating the body. In the interest of time, Mr. Chairman, I'm going to ask your permission to withhold my remarks till the end of my group speaks. That way we'll probably cut down on some redundancy and I can finish with that which has not been addressed. But I do want to point out just a couple of things. One, this bill is very different than the legislation that was considered last year in the special subcommittee. This bill has statewide effect. It is not restricted to rural hospitals. So whatever is decided and whatever goes into law, if there is a change, is going to impact every healthcare facility where anesthesia is required. And I lay that on you because this is so much bigger in scope than the legislation you looked at last year. Also in your packet this morning are two pieces of information. One is a letter from the Georgia Society of Oral and Maxillofacial Surgeons opposing this legislation and very aptly describing why they oppose this legislation. And I hope that you'll take time to read that. Also in your packet is something that was missing yesterday in verbal testimony, and that is a comparison of training between anesthesiologist and nurse anesthetist. And it's a long grid, but it's extremely informative and speaks to the type of education and training that occur along the pathway for a physician, an anesthesiologist, and then a nurse anesthetist. And I hope that you'll take time to look at that. But I don't want you looking at those while our speakers are talking. Mr. Chairman, who is the next speaker listed on there?
Well, you've kind of given me pause and wonder whether we got enough time when you say you want to let them file up here and speak, and you're going to do the summation, but whoever you wish.
All right.
This is y'all's time if you want to.
Right.
If you want to line
All right.
them up.
Well,
And
here's what we have today. We brought 2 medical students because this bill impacts the future of those medical students. Because this legislation will change the way hospitals staff anesthesia departments, and it will affect it significantly. Then we also have a resident physician, and I brought physicians who have been in practice for quite a long time. So I'm going to ask Dr. Steve Sween to come first.
If you're going to be the marshaling of
Yes,
this
sir.
side, then you can introduce them and bring them up in whatever order.
Thank you. Dr. Sween is cardiac anesthesiologist, having practiced at Emory St. Joe's, and I know that he will provide you valuable information.
Is Dr. Swain on the list yet?
He is. Let's check them all.
Thank you, Jet, and thank you folks for the opportunity to speak with you today and try to inform you about the practice of anesthesiology, certainly at least as much as I know it, having practiced at Emory St. Joseph's for a long time. I brought some scripted remarks. I think I can get more of my points in if you just allow me to use my scripted remarks, and certainly I'll avail myself to any questions at the end. So again, my name is Steve Sween. I'm a recently retired physician anesthesiologist. I reside in Sandy Springs, and I've lived there for 39 years. The past 34 years, I've practiced at Emory St. Joseph's Hospital, formerly St. Joseph's Hospital of Atlanta. I practice with a physician specialist in anesthesia practice group, or PSA. At PSA, our clinical practice mode is primarily the physician-led anesthesia care team, involving physician anesthesiologists working alongside both certified registered nurse anesthetists, or CRNAs, and certified anesthesiologist assistants, or CAAs, to care for the busy and often complex high acuity adult surgical and medical procedural patients that we are privileged to serve. I've worked with hundreds of anesthetists over the years, both CRNAs and AAs, and I have a great deal of respect and experience regarding the important role that anesthetists play in the care of surgical patients during the perioperative period. However, foundational to that success, efficiency, and patient safety and optimal course is the leadership, the depth of experience, the academic background, and the immediate availability of the responsible physician. In my experience and supported by the anesthesia literature, the physician-led anesthesia care team is the safest mode of anesthesia practice for many reasons, including having 2 caregivers immediately available for the critical elements of routine care, as well as immediately available for the unpredicted, urgent, and emergent events that occur more frequently than most people are aware. Early recognition and intervention is critical to avoid serious adverse outcomes when things deviate from normal, and that is where the physician's experience and support is integral to the patient's perioperative experience and good outcome. You simply cannot eliminate, quote, administered under the direction and responsibility of a duly licensed physician, end quote, as proposed in this bill, and expect the same ability to successfully respond to and appropriately intervene in anesthetic urgent and emergent situations. This proposed amendment in Georgia Code to the Georgia Code represents a significant change, very significant change, I think, a step backward rather than a forward progress to the practice of anesthesia care in Georgia. And I urge you to oppose it on behalf of the surgical patients and their families, your constituents, and your community. A little bit about myself. My routine anesthesia training was followed by a cardiac anesthesia fellowship at Emory in 1986. That's right, way back then. A full and intense year of doing anesthesia for only cardiac and thoracic procedures under the direction of the outstanding faculty at Emory University Hospital at that time. I thank God for that opportunity that brought my wife and me to Atlanta and to Georgia. My subsequent nearly 4-decade career was focused on the care of cardiac surgery and critical care medicine patients, thousands of them, working together with CRNAs, AAs, and nurse practitioners and PAs on the critical care side. Don't you think that depth of experience and training provided a higher level of care, patient safety, and improved outcomes? I certainly do. My oldest daughter, Lindsay, is an obstetric anesthesiologist at Northside Hospital and Health System. Like Representative Dr. Michelle Au, she also holds a master's in public health. After Lindsay completed a 4-year undergraduate degree at Davidson College and 4 years medical school at the University of Pittsburgh, she completed a 4-year residency in anesthesiology at Beth Israel Hospital in Boston. Then, she elected to do an additional fellowship in obstetric anesthesiology at the same institution, one of the Harvard-affiliated hospitals. For a full year, she only performed anesthesia for obstetric patients, often very high-risk and high-acuity patients. Don't you believe that her level of intense and extensive training and experience brings advantage and significant improvements to the physician-led obstetric anesthesia care team? Of course it does. It makes a huge difference. Now, I realize that these examples of cardiac surgery and high-risk obstetrics might be perceived as extreme, where a solo, independently acting CRNA will not likely be positioned without physician direction and support. But there is nothing in this proposed bill, House Bill 251, that precludes the independent, solo participation of a CRNA in even the most high-risk, high-acuity, and challenging anesthesia cases. The advantage of at least 2 people working together, 2 heads and 4 hands, is imperative for the best results in these very complex cases, and any other case where unexpected challenges may arise. In closing, I will reiterate my strong and informed belief that with this straightforward warning, if this is adopted and fully implemented, this modification to Georgia Code will increase the risk for and the incidence of serious adverse perioperative events for surgical and procedural patients. It is simply a fact that you cannot eliminate the physician from physician-led anesthesia care and expect to obtain the same results in terms of patient safety and quality outcomes. It's just that simple. I thank you very much for the opportunity to present my points today. I'm available now for questions or anytime, and Jet knows how to get a hold of me. Thank you.
I'd like to ask a question, Doc, and thank you for taking that time out of your busy, well, you're retired, so you ain't got a busy schedule.
Well, I canceled a golf game, so.
Can I give you a special thank you for that then? One of the issues that we keep hearing is about across the breadth of Georgia that they're having problems getting anesthesiologists outside the metro area in the smaller, the more rural areas. Do you have any comments or suggestions about how that could be remedied? Because the lifeblood of a lot of hospitals is based on procedures to offer services and all. Can you give any of your ideas on that?
Well, clearly there are more anesthetists than there are anesthesiologists. That's just a fact. They are, and there are actually more anesthetists being trained currently than there are anesthesiologists. But the number of anesthesiologists that can be put out is is not infinite, it's finite. The numbers are increasing slowly. There's issues of federal funding and residency training positions and that sort of thing that hold up the numbers of anesthesiologists. And clearly, like myself, I prefer to be in a suburban area rather than a rural area, even though I grew up in a town of 837 people in Minnesota. So I know about the rural situation. The current rural setting, of course, is that the surgeon has direction over the anesthesia, and most of the anesthesia in the really rural settings is provided by CRNAs. And to be honest with you, Georgia does a really good job. I know there's a shortage. There's a shortage of every kind of physician provider. There's a shortage, the workforce shortage of anesthetist providers. I actually participated on the American Society of Anesthesiology workshop, seminar or workshop, what was it called? Anyway, 2 of them, and these are being discussed. It's going to get corrected. The market will correct it, but it's going to take time. Now, whether the small, really small rural areas are ever going to have an anesthesiologist, I doubt that's going to be the case. So I think we have to do the best job that we can with the current situation that we have. And I also will say that Georgia is in a really good place relative to other areas in the country. I've served on the ASA Board of Directors for over 20 years and was an officer for 8 years, so I'm very apprised of what's going on across the country. First of all, Georgia has a really good situation because we have 2 levels of anesthetist providers. We have CRNAs and we have AAs, and they both work pretty much interchangeably, except in that rural setting because the AAs can't work under other than an anesthesiologist. But I would tell you, we have 2 excellent anesthesia programs in Georgia, Medical College of Georgia and Emory putting out highly qualified anesthesiologists. We have 2 AA programs in Georgia. I think it's 2. I'm pretty sure it might be 3, but I'm pretty sure it's 2, putting out AA providers. And we have 2 CRNA schools in Georgia, one at Emory and one at what I'll call Medical College of Georgia. I don't know what the current name is, but that's what I call it. And those programs are putting out excellent caregivers. So we have a really good situation in Georgia. There's a shortage, but the shortage is less impactful here than it is just about anywhere.
Let's see, now we've got some questions on the board. Representative Chairman Carpenter.
Thank you. I appreciate you being here. Appreciate your service to this state. My question is, since you said 1986, it made me think, were you around when the code section was opened up originally? I'm sure CRNAs have not existed forever. So were you around when we started allowing them to operate in the state of Georgia?
No, I don't think. I might have been, but I was in training at that time and busy starting a new practice, so I wasn't as involved until about 1991 or 92. But CRNAs have been in Georgia and everywhere for a long time.
Okay.
They have a long history of being available and giving excellent care.
Sure. I just want. I mean, obviously, I don't have the history or the background on the profession, but I just wonder if we were having similar fights, that the care was going to diminish at that point. You see what I'm saying?
I do.
I wonder, the original fight, was this the same conversation? Then we opened it up a little bit, and it didn't ruin the world, I guess.
I will just, if you'll allow me to say, the pursuit of independent practice is more of a modern thing. Didn't go back to my early days.
Chairman Cooper. Oh, I'm sorry. Number 12. Who's doing? Oh,
On 12.
Chairman Jaspers, I'm sorry.
Thank you, Mr. Chairman. You brought up a term that I'm not familiar with, and we're looking at Mr. Tony's description here of a certified anesthesiology assistant. I guess I just know what that is, and what's the difference in that and a CRNA? I don't want to confuse the issue you have at hand, but it seems like a third part here.
This might be redundant because there's I'm guessing there are going to be some CAAs that are going to testify today, but I will just abbreviate what the CAA is a unique concept. Actually, what initially was unique to Georgia and to Cleveland, Ohio, where the 2 programs in the early 1970s started a program for people who did not do a nursing route to anesthesia practice, but actually a lot of them pursued respiratory therapy. Many of them pursued medical school but weren't quite able to get in, and they created a new care provider called an anesthesiologist assistant. And what that person did was do a 4-year college degree with many of the same sort of pre-med requirements that it would take to get to medical school. In other words, a science background. And then they would take a program at either Emory, or initially Emory or Case Western were the two programs that were involved. And then they would do somewhere in the 27 to 28 month of rotating through an anesthesia training program.
Okay.
Many of those have, I usually say there's about a 50-50 mix of CRNAs and AAs in the Metro Atlanta, greater Metro Atlanta area. I'm not sure how accurate that is, but I think it's pretty close. And it's a different type of anesthetist provider. There are many of these programs now building up around the country. There may be 21 to 25 states that now allow and have training programs for AAs, but I still believe there are more AAs in Georgia than anywhere in the nation. And that's what I was referring to as Georgia's in a good place.
Okay. Thank you. Thank you, Chairman.
All right. Representative McDonald.
Thank you, Mr. Chairman. Thank you, Doc. I appreciate you skipping your golf game on this beautiful day. I think. Well, he said it.
No, I wasn't being facetious.
Yeah. Oh. Okay. I mean, no, but you got to listen to what he says. All right. Yeah. I'm not being a jerk.
No. That wasn't who I was
Oh,
referring to.
okay. Who are you referring to? All right. Back to the question. Appreciate what Chairman Powell said earlier. It's in this bill. Our common goal here is to getting adequate and accessible care for all of Georgia, mainly rural Georgia. It's kind of where this bill started last year. And I look, as you've read the bill and very knowledgeable of the profession, what would you change in this bill if you could make it a better bill and make it where it would help rural Georgia? What would you do?
Well, I think the most, obviously, I'm most critical about taking the physician leadership out, breaking it away, because that just doesn't affect rural Georgia. It affects all of Georgia, as Jet Tony said earlier. I think the situation with rural Georgia is the same thing in Georgia as it is in rural America. And young people don't want to live in the rural areas. Young people are leaving the rural areas. Old people are staying around and trying to do the best they can. But as I said earlier, I don't think that the current situation in Georgia, with the rural surgeon being in charge, having oversight, if you will, and needs to be apprised of what's going on the anesthesia side. But the nurse anesthetists do, I'm sure, overall they do a fine job. Like everything, there's a bell-shaped curve to just about everything. But overall, I think they do a fine job, and many of the nurse anesthetists want to live in the urban area as well, just like many of us. But if you're going to focus on the rural area, then I think the bill has to focus on the rural area. But to be honest with you, I don't think this bill adds anything that is going to increase the number of nurse anesthetists in the rural area, because I would tell you what I know about how nurse anesthetists do in rural settings, they do very well. So I think it's just the problem of rural medicine in America. And I don't see that this bill, as it's written, makes any significant difference to that.
Well, it's yesterday. Of course, you weren't here.
I actually watched the testimony.
Oh, you did?
yesterday,
Okay,
yeah.
good. All right. You heard me mention. I'm from rural Georgia and grew up in a small town that the hospital was there as when I was a child, but of course doesn't exist anymore. I mean, it kind of got eaten by two hospitals, so that town care is not there anymore. You have to go to Athens, go to Gainesville, which are two great hospitals. But now that I live in Forsyth County, one of the wealthiest counties, or the wealthiest county in the state, I've talked to anesthesiologists have called, and I'd ask the question, would you like to move to rural Georgia? Would you like, and everybody's like, no, our school systems are great here in Forsyth County. My family, that's where, sports, et cetera. And so that's something that, being from rural Georgia and watching your own hospital down a vine, it's important. I mean, I've ridden all over this state. When I go to the beach, St. Simons, I don't just use 16. I love to go through the backcountry, and I do care about rural Georgia. And I just want to find a happy medium that we can get to that brings good quality and accessible care to these areas.
I completely understand, and I have a affection for rural. As I said, my hometown of 837 people. The reason I went into medicine was the family doctor in our town. He was a doctor of one, family medicine, lived on the opposite corner of us on our same block. And I watched him go and come, and the service that he provided made him the most revered person in our community. That's why I went into medicine. In fact, I went into family medicine, and I went into rural family medicine. But I decided that wasn't for me. And after 5 years of both training and then 2 years of doing it, I left that and went to anesthesia. So I understand the situation in rural America is not on the upslope in terms of medicine and providing medical care, but I think it's a programmatic thing that is much bigger than anesthesia and any specialty for that matter. I think we're going to have to provide some incentives for going out there, reducing debt burden or whatever it is to get people there. But it's a big problem.
When going back to anesthesia, of course, I grew up in Commerce, Georgia, which is next to Jefferson, where Crawford W. Long was where he lived. In the early days of anesthesia, were there anesthesiologists? Were nurses? Who was providing anesthesia to patients? Was it doctors, nurses, or were they anesthesiologists?
When I first started my career in 1980, my first job was 1987. I helped start the new open heart program at Piedmont Hospital. I gave the first open heart anesthetic at Piedmont in February 1988, same year my oldest daughter was born that I talked about earlier. But anesthesia at that time was not solid, and it needed a lot of help. Big hospitals in Atlanta were just getting around to having really good solid programs, but and there was a lot more dependency on anesthetists at that time, I think, and it was much less structured. It was actually a lot more dangerous, and the outcomes weren't nearly as good. And then something happened in the mid-1980s, about the time that I made the change, where anesthesia became very appealing. And I don't mean this in any way, but prior to the 1980s, most of the anesthesiologists in the country were foreign medical grads, and many of them had language barriers, and that anesthesiology was a better place for them to be than maybe in an office practice. And I don't mean that in any disparaging way. That's just the way it was. But that all over the period of about 10 years, that completely evolved, and to the point now where still some of the brightest and highest academically achieving students want to be anesthesiologists.
But backing up a little bit, was it even before your time, who was providing anesthesia? Was it nurses or doctors or whom?
It was still a mix. At Piedmont Hospital, when I joined it in 1987, it was all physicians. There were no anesthetists at all. And with that open heart program, we brought in an anesthetist. At that time, Kennestone Hospital was, I think, all physicians. Northside had gone to a care model like it currently is. But the rural area was still, there were no anesthesiologists in the rural area then, and there are very few now. Some of the more larger rural areas have anesthesiologists, but the really small ones like you and I came from,
yes, sir,
probably don't.
Thank you.
All right. Representative Smith.
Thank you, Mr. Chairman. In certain states, CRNAs have been allowed to practice for over 2 decades. Do you have any proof, statistics that back up that the level of care will be diminished if HB 251 is enacted?
I don't know how many states have complete independent practice of CRNAs, but it's not that many. Now, Medicare has had what's called an opt-out program, where nurse anesthetists don't necessarily have to fall under the Medicare guidelines in their practice. But even in most of those states, and there are probably about 20 of those states, and that may be what you're referring to is about the Medicare opt-out, but even in those states, in most acute care settings in an urban area, they are still practicing under the direction of or supervision of a physician, just essentially like it is in Georgia, even in those opt-out states.
Just a statement, Mr. Chairman. I'm a little concerned with these baseless claims that people are making in this committee about the level of care being diminished when there's evidence, or at least CRNAs have been in practice for a very long time, but yet no one can point to anything bad happening. Thank you, Mr. Chairman.
Thank you. You know, I'll ask you the same question I keep asking folks. You know, we heard testimony yesterday, and I get a lot of confusing comments that are being made. But we had somebody testify yesterday, talked about a family member who had regurgitated, passed on the table. And that was being handled by CRNA. So are we allowing CRNAs to do procedures without supervision of an anesthetist?
Well, without anesthesiology supervision, yes. But in that case, that was a GI, so I won't call that person a surgeon. They were a proceduralist. So, but in other words, there wasn't open surgery. Remember, that was an endoscopy case. I saw Dr. Kaufman's testimony, and so that was a CRNA working under the direction of the endoscopist.
So you're saying the lesser procedures, an anesthetist can fill in those without supervision?
That is occurring in many levels, both in the metro area, particularly in GI centers, as well as in the rural area. That's what, the surgeon has responsibility for the oversight of, or direction of, or whatever you call it, with the CRNA. But that's not full independent practice, right? What I'm talking about independent practice is taking away the requirement for direction or collaboration.
Very good. Let's see, Mr. Washburn.
Thank you, Mr. Chairman. The recounting of the loss of the patient yesterday by the doctor, but can we say without a doubt that had there been an anesthesiologist supervising that death would not have occurred?
No, there's no certainty like that you can ever say. But if there was had there been a supervising anesthesiologist who was immediately available and responded immediately, it would have increased the likelihood of a more successful outcome. That was a devastating outcome on a very young person. And I know that case because the patient was transferred to Emory St. Joseph's Hospital but was unfortunately already brain dead. So I don't know if that answered your question, but you can never be sure when the emergencies arise. But what Dr. Kaufman said yesterday, that young CRNA testified, I assume, I don't know where it came from, but that she had never intubated a patient with emesis. Well, most anesthesiologists have that experience, more than once, in fact. So that's kind of what I would say about that.
All right. Doc, we appreciate you taking time to come up here.
Thank you. It's been a pleasure.
After April 4th, you're welcome to
Thank
come
you
up.
for all you guys do for the state of Georgia.
Yeah. After April the 4th, you'd be welcome to come visit Hartwell for a dandy good golf course I've got up there. Now, the anesthesia I use on the golf course ain't the kind you administer. All right, next up.
Mr. Chairman, the way that we would like for this committee to look at this bill is, we're not going to berate CRNAs or CAAs or anesthesiologists or surgeons. What is the case in Georgia now, Mr. Smith, is there in most places in Georgia where anesthesia is delivered, there's backup in most places. Where there is not backup, to Dr. Newton's statement, there is a captain of the ship, and it's the surgeon or the proceduralist in the endoscopy example. There is someone that makes the ultimate decision. It would be wonderful if we were pre-1991 and CRNAs could only practice under an anesthesiologist, because that assured backup wherever anesthesia was provided. But in 1991, the legislature recognized that there's not enough anesthesia providers, period, and so the law was changed to allow CRNAs to practice under the direction and responsibility of any physician. And that broadened the job opportunities for CRNAs. Now, I do want to address something that you, Mr. McDonald, have said a couple of times. You said you talked to the anesthesiologist at Northside Forsyth, fabulous hospital in your district, and you asked the anesthesiologist where, would they move the rural area? Well, no. Did you ask the CRNAs, are they going to move to the rural area? No. You moved from a rural area to a more populated or a rapidly growing area, and as Dr. Sween said, that is the way of the world. So what can we do? What can we do? What can you do for rural health care, period? Dr. Sween began to address it, and I want to remind you that last year during the hearing, when I spoke to you, that I pointed to you a report and research that the Georgia Society of Anesthesiologists did, and that was presented to the Senate Rural Medical Personnel Recruitment Study Committee over 2 years ago. And in this document are about 10 to 15 suggestions that members of the legislature can do to incentivize the movement of physicians to the rural areas. Back in the 90s, Mr. Carpenter asked a question about, the history of anesthesia. Let me see if I can get my train of thought back on this. I may have to come back around to it. These recommendations, frankly, thank you to the legislature. Some of these recommendations are being done. You as legislators are appropriating money for more residency slots across many specialties. That's probably the easiest thing, and it does require money, but it'll put more anesthesia providers available to go to the rural areas. In here are recommendations, and this is a much better solution to rural health care and recruiting healthcare personnel to rural areas than removing physicians from the decision-making continuum in a surgical procedure, and that's what this legislation does. Mr. Chairman, may I address the bill, just some elements of the bill, and then give it some life, how it's going to affect Georgia? I know we're running out of time and we're running out of people.
You seem to have a number of people to speak today. You certainly can.
I do, and I may ask them to shorten their presentations. This legislation gives hospitals and other healthcare facilities the authority to remove physicians from the decision-making processes necessary to assure as successful an outcome as can be had, given the patient's level of acuity and given the injury or the disease that is being corrected. Now, so don't be mistaken with all this language about coordination, because, and Dr. Newton addressed that, coordination is as squishy as you and your spouse saying, where are we going to go to dinner? And she says, I don't care. And you say, I don't care. And then, you drive around 15 minutes till you decide on something. It's squishy. Coordination actually does go on now, but there is an ultimate arbiter of the decision that is going to be made on behalf of that patient. So don't be distracted by some of this language in this legislation, because the nut of it is that the language administered under the direction and responsibility of a duly licensed physician is struck, and you lose that. And the decision you make about this bill will follow you throughout the rest of your career and will affect surgeries all over the state. Now, if this really was about getting rural surgeons to stay in rural Georgia, then the language indemnifying surgeons would have remained in the bill, but it's not in the sub. So there's a clue that this bill really isn't about getting surgeons to stay or to go to the rural area. There are so many reasons why surgeons won't go to the rural area. Dr. Swain addressed it. There's so many economic factors. There's reasons anesthesiologists won't go to the rural area. And in surveys that we did back in the 1990s, we found out that the anesthesiologist trainees are taught on modern equipment, the most contemporary equipment. When they go to the rural areas, they're going back a few steps in equipment. And there's a concern among anesthesia providers, I don't know that I want to treat patients with that equipment that is somewhat outdated. Now, CRNAs are not going to flock to the rural areas under this bill. CRNAs that want to practice in the rural area, practice in the rural area. Why? Because, one, they make great money. By the way, did you know that CRNAs make, on average, $250,000 a year in this state? It's pretty good money. It's pretty good money. Anesthesiologists make good money. Other physicians make good money. So we're not talking about holding down CRNAs because they have to be directed by a physician. What we're saying is to get people to go to the rural areas, we've got to do a lot more. We've got to do a whole lot more. Now, the military example that was used, there's a good number of reasons why anesthesiologists aren't on the front line. One, there are not enough anesthesiologists to serve on the front line. But if you want to be hard about it, the reason that they don't put anesthesiologists on the front line is that the armed forces put a lot more money in the training of anesthesiologists. And Dr. Reel, who's with us, and is going to testify, is going in the Navy, correct? The Navy, Air Force, excuse me. But in the military, they're not going to, with all that investment in those doctors, they're not going to put them in the most harm's way. Now, the other reason that it's hard to get anesthesiologists to go to the military is because an anesthesiologist is probably going to be a captain, and he could be overruled by a CRNA who's a colonel. So there's a hard tension about rank in there, even though the physician may say, we need to be doing this, or this would be a better way to treat these patients or these procedures, but could be outranked by a colonel that is a CRNA. Now, Mr. Chairman, I want to be respectful, and I may be willing to ask my presenters not to present if you think that's an appropriate thing, or we can ask them to give a 2-minute version.
Well, this chair has always had a methodology that I believe everybody has a right to be heard. Once that right to be heard has always been repeated over 3 times, and I step in. I do have a couple of questions for you.
Yes, sir.
You made a comment a while ago, and I want to be sure I heard what you said. In 1991, the legislature opened the door for anesthesiologists.
No, they opened the door
excuse me, for
nurse
anesthetists.
anesthetists. Yes, sir.
And that was, and you said to work under the direction of
Right. Of any physician.
of any physician.
Right.
So is that where we're seeing a situation where CNRNAs are doing anesthesiology work under other docs?
Well, that's the
without
case.
being under the supervision of an anesthesiologist?
Well, in the places where an anesthesiologist is not present, a nurse anesthetists are allowed to administer anesthesia under current law under the direction and responsibility of a physician, a captain, someone who's the ultimate decider of the treatment plan. And we believe, to Mr. Smith's point, we believe that's as good as we can get in some places. And the legislature obviously back then felt that. But if we remove that physician participation, then we will have a situation where we have removed physicians from the deciding factor. I'm going to give you an example. I'm going to call the name of the hospital that is already implementing what's the type of plan that is anticipated in this legislation. Piedmont Columbus has thrown out its current anesthesia group and has gone with an anesthesia company that advertised that it would be a collaborative practice, coordinated practice, very CRNA heavy. In other words, they're running off the anesthesiologist assistants. In fact, their ad says no AAs need apply. They're running off the anesthesiologist and saying, we're going to have basically only CRNAs. We may have an anesthesiologist, but there may be 7 or 8 concurrent cases going simultaneously, and there's no way that one anesthesiologist can be immediately available to 8 rooms. And so I think that hospital administration that went with profits over patients has decided maybe we need to talk to this new group and see if we can get them to alter their plan and bring in the anesthesiologist, just like that hospital has had forever. You can't go cheap. You cannot go cheap in anesthesia care. It's too important. And I think what the hospital is going to find out, the same thing that happened to this company in Portland, Oregon. This same company moved into Portland, Oregon at one of the hospitals. They can't handle the cardiac cases now in that hospital because they can't get enough personnel, and because there's not an anesthesiologist there, they don't have the smooth operation. They don't have the physician direction that they have. And so we know what's going to happen under this bill, and it's going to be that some hospitals are going to go cheap, and they're going to put profit over patients and run off physicians. Again, it's about backup. It's about backup, and we have backup in our current law. I'm going to ask Dr.
Wood, you have a couple of questions.
Okay.
You've talked about long enough. You've backed yourself into some questions.
Okay.
Let's see. Representative Earhart.
Thank you. And to my friend, Mr. Tony, thank you for being here today.
Thank you.
Do have some questions, a couple of quick ones, if I may. Which hospital system did you say is transitioning to the CRNA-based?
Piedmont Columbus.
Piedmont Columbus.
That's 2 hospitals and soon opening a pediatric hospital.
Right. And I would wonder, Piedmont I know is an excellent operation. And I understand that sort of that catchphrase, profit over patients, but I find it hard to imagine that a hospital system of that magnitude would make such a decision without having clearly weighed all of the pros and cons. And it seems to me it's unlikely that a system of this size would just purposely put its patients in jeopardy.
Well,
I'm sure it wasn't this decision would not have been taken upon lightly, I would imagine. A significant amount of analysis was done before a decision like that was made.
Well, I think the analysis was this anesthesia group came in to the administrator in Columbus. Now, this is not a system-wide Piedmont development yet. Might be in the future. You need to think about that if you're a Piedmont patient or your loved ones are. But the administrator of that hospital said, we're going to try to reduce the cost of anesthesia services. And so that's why they did not renew with their existing practice group, and they're going with a more nurse-centric plan.
Right. Even so, even if cost savings is one of the benefits, I find it difficult to believe that they would take such a measure if they truly felt that this was going to jeopardize patient care. And it kind of circles me back to something that my colleague, Representative Smith, asked about earlier. Certainly, this committee makes decisions based on fact. I would imagine the hospital systems, hopefully, are making decisions based on fact. And I have yet, even though it's been asked numerous times, to haven't heard anyone giving testimony actually give us some statistical analysis to show or prove that patients that are under the anesthetic care of a CNRA are at any increased jeopardy of a negative outcome as a result. I know there's been a lot of, what I'm hearing is a lot of, we're surmising or we're estimating or we're suspecting, but I'm not seeing any data of any kind. And I'm just a numbers girl. I like to work off of the
up, and hopefully it will go all the way this time. But thank you for making this this part of history.
I would circle back real quick just to tell you that I would just kind of want to make a point on some testimony that was given yesterday by the doctor that had lost his nephew, which is a terrible and a tragic story. And I'm so sorry to hear that that happened. What I have often learned, just from having been around a little while now, there are oftentimes tragic and terrible stories on both sides of an issue. So for areas of our rural state that are drastically underserved by availability to anesthesiologists or CNRAs or any of that sort, you know, what are the sufferings and the problems and the negative outcomes that are happening as a result of that? Not to in any way demean anyone's sad story, but I know that sometimes you can find that on both sides of an issue. So that's why I circle back kind of to the fact-based. Where's the evidence?
Well, I'm going to be blunt, and my clients may not like the way I say this, but I've said it for other clients. I've seen so many studies through the years, and they all seem to me to point to what the author of the study wants to point to. But what I think what Dr. Sween would respond to you is in those Western cases where there is more independence of the CRNA, but there is a physician obviously there. Those are lower acuity cases, and most nurse anesthetists administered anesthesia administered cases tend to be lower acuity. So the data's very friendly for them. And but when you, so I'm going to appeal to every member of this committee's common sense. Do you want one person in charge of the anesthesia, or do you want two people, the two heads, four hands, using all of their collective knowledge and experience to rescue a patient that decompensates?
Thank you for your answer. Mr. Chairman, if I just have one last quick question, and that is another thing that I have heard, a phrase I've heard a couple of times is removing the physician from the equation, or removing the physician. And so we've been dealing a lot with definitions. I know Mr. Chairman will probably agree with me. Yesterday we were talking about the difference between injury and condition. Today we're talking about perhaps the difference between supervision and coordination. And I feel a little bit like a picture is being painted here that this physician is just completely being removed from this equation. And I think it's important, just looking at the bill right here, and I know you said that coordination is I think you described it as a squishy term. Lines 18, this is the expectation of the interaction between the CRNAs and the physicians. Coordination means the process in which a physician and a certified registered nurse and anesthetist work together to manage a patient's care, including but not limited to sharing information, discussing a patient's diagnosis, condition, and treatment, and developing and modifying an anesthesia plan to ensure the best possible delivery of health care. I understand a little bit about coordination simply because I actually know, I probably only know one CRNA, but I know a lot of nurse practitioners and advanced practical nurses, and I know that this coordination is actually an essential component of their job description. When you're talking, and I know Dr. Newton mentioned earlier, sometimes these are chaotic environments, it's noisy. These nurses are, I believe, laser beam focused to thrive in those situations. Anyone in those roles, and this is my understanding, I know at Wellstar, because I've heard this discussed, anyone in these roles at Wellstar that are not competent and effective at the art of coordination, they're rooted out. They don't survive in those roles. So I just kind of wanted to bring it back here because I feel like it just keeps showing like we're just removing the doctors completely, and yet I understand the expectation of this bill is this coordination, which is quite defined in the bill.
Well, it's defined, and it's actually, that's what's happening now. There's coordination. But again, somebody has to be the captain of the ship. And without it, we're entering just a different health policy with regard to who's going to be in charge of the patient care.
Right. And if I may, just my final point, Mr. Chairman, which kind of brings it back down to what is real crux here. We would assume that most of the time this coordination is happening effectively and in the best interest of the patient. You're really talking perhaps the concern here is that that physician and that CRNA might reach a point where there's a disagreement, right? Where suddenly this physician now needs to step into this role of overriding the CRNA, exerting his supervision or his authority. How often does that even happen? You know, again, I don't know that we have any data on this to show how often a physician requires that supervision role so that he can intervene in that situation and override the CRNA. Is that, I haven't even heard, is that even an issue or a problem that we're having?
I know of one case where it's an issue where the CRNA claimed the anesthesiologist brutalized him or assaulted him when all the anesthesiologist did, because the nurse anesthetist was not willing to follow the direction or the order prescribed by the anesthesiologist, and was saying all of his argument in front of the patient who was not sedated, fully awake, and the anesthesiologist touched the elbow of the CRNA and said, let's go outside and discuss this away from the patient. And then the CRNA turned around, filed a complaint with the police department. The anesthesiologist was arrested, had to hire a lawyer, fight all of that. Thankfully, there was video of all of it there in the operating suite. Otherwise, but it, you know, does it happen often? No, but that was an egregious thing that chilled me. And this was a rural area, by the way, where an anesthesiologist was in charge. So, you know, in most places, it's going to be smooth running. I think Dr. Sween testified to that, smooth running. But again, this bill removes backup. This bill encourages hospitals or allows hospitals to remove backup. And that's what we're seeing in Columbus. But I will tell you this, thankfully the surgeons in that hospital woke up and went to the hospital administration and said, you need to rethink this, because we need anesthesiologists in here coordinating this care, keeping our lines running smoothly, and making sure we have backup. Because one of those hospitals is high acuity, and going online is that pediatric hospital where you really need the most specialized type of anesthesia, perioperative care.
All right, you've talked yourself out.
I have.
We've got one more question. I want to ask a quickie, and this should not take you over 30 seconds. In any case, is telemedicine that we've touted for years in the legislature, is any place for telemedicine to help in the dealing with anesthesia?
With anesthesia. Well, a Texas Anesthesia Society 3 years ago called the Georgia Medical Board and said, can we supervise CRNAs through telemedicine? The medical board said, no, you have to be immediately available to help the patients, to monitor. You cannot be ever how many thousand miles away.
Quick enough answer.
Yes, sir.
All right, Representative Williams.
Thank you, Mr. Chairman. Mr. Tony, forgive me if this question's already been asked and answered, but with the direct supervisory role that the physician has now, he or she's ultimately going to be more responsible for the patient's care. And when there is something that goes wrong, does it make sense to me that it's going to, we talk about water flowing downhill, but it's going to go back uphill as far as professional liability insurance is concerned? And what I'm particularly addressing is malpractice insurance. And it's my understanding now, correct me if I'm wrong, but in general, if you have a surgeon or a physician, and I know that it's going to be much more for OBGYN and less for certain type of physicians, but let's say the physician's paying $30,000 or $40,000 a year in medical malpractice insurance. Is my understanding that they can add, like it is a surgeon, they could add a CRNAs to their policy for a couple of $1,000s a year. It only makes sense to me if we decouple the supervisory role, then something's going to rebalance on the professional liability end. And I would just urge our very valuable CRNA community out there, if this bill does move forward and if it becomes law, that they better be paying attention to the fact that you're going to be more responsible when your med-mal premiums are fixing to skyrocket over time. And is that not true?
Common sense would tell you that the exposure increases.
Okay, and then my final point on that is I've been observed American business, participated in American business now for a long time, and I've never seen a clear example when you have two CEOs running, co-CEOs of any organization, and right now we have a supervisory role, not two CEOs in the operating room, or as my wife likes to put it, you better not have two cooks in my kitchen. She kicked me out a long time ago on that. So I just think we need to keep the supervisory role that we have now, so I'll be voting against the measure.
A very wise legislator told me one time there has to be a pecking order.
All right, talk about the pecking order. I don't see any more. Well, I'm sorry.
Okay.
I'm sorry, I
Mr.
do see
Chairman.
one more. Ms. Earhart.
No, that was not me.
Oh, it's not.
Oh.
Mr. Chairman, the balance of our speakers yield their time.
And I thank you, and I'll start calling them. Dr. Reel? You're going to yield? All right. Are you the one that's going into the Air Force? Or you're in the Air Force?
That'll be my first job after my residency training finishes at Emory in June. Thank you for your service.
Why would, I just have to ask the question. Out of love for your country, why would you be going into the Air Force and turning down a six-figured salary to go in there to?
So I'm with a lot of family members who've gone through the military. I'm very interested in serving our active duty patient population and our veterans.
Wouldn't have anything to do with the student debt or extra training it would save or whatever.
I didn't save any extra training, that's for sure. But it did help with debt relief as well.
Well, thank you for making that option. Appreciate it. All right, Hunter McWilliams.
I also yield my time.
I guess Jet just wore all y'all out and said what y'all had to say. Herzo Chima.
Over here, I yield my time.
Really? Justin Ford.
Right here, sir, and I yield my time.
Jordan Agner.
That's me, yes, sir. I yield my time.
This almost sounds like a courtroom. Brett Walker.
I yield my time.
Jim Davis or Tim Davis.
Thank you, Chair. My name is Tim Davis. I'm the Director of Government Affairs with the Georgia Nurses Association. We're the largest association representing professional registered nurses in our state. I know the foresight was yesterday, but happy to be able to bring some comments towards you. I think what's at the crux of this issue is the reality of the boots on the ground in our state. In many health systems, there is no anesthesiologist available in those communities. We understand that health systems rely on these surgical services from a viability standpoint to be able to provide all of the care that they provide to the communities that are already underserved. And so I would encourage you to keep those constituents in rural Georgia in mind as you decide whether or not you're going to vote yay or nay on this, and empower those health systems to be able to do what they need to do to keep their doors open and providing services for their communities. And I'll leave it at that.
Any questions? Do we have any questions from the gentleman? You got off luck. Juliana McConnell.
I'll be brief. And I do, we do work closely with Georgia Nursing Association with Tim, and I represent the United APRNs, the Advanced Practice Registered Nurses of Georgia, and they just asked me to come today just to, as the GNA did, to express our full support for this legislation. Thank you.
I see no questions. Well, we've just exhausted the sheet because of so many abstentions. Do we have anyone here that wishes to be heard this morning that didn't sign up? I have a hand in the back of the room. If you could come up and identify yourself again.
Yes, sir. Thank you, Mr. Chairman. Thank you, committee. You heard from me yesterday. My name is Matt Oxford. I'm the president of the Georgia Association of Nurse Anesthetists. We've heard a lot of testimony for and against this bill, and I think we all really know what this comes down to. We're fighting for the patients. When we talk about those numbers, as you alluded to, there are 25 states who have opted out of the federal requirement for Medicare. That's a billing term. 36 states have already changed their legislation to remove direction or supervision within their legislation, within their states. Of those, such as Minnesota, have some of the best healthcare outcomes in the country. We're not fighting to harm patients. That's not on anyone's agenda, but we're fighting for the truth. And right now, the truth is CRNAs are the primary healthcare providers, the primary anesthesia providers in the state of Georgia, especially in rural counties. When we talk about the medical direction and the anesthesia care team, we only look to that case that came out from Macon 2 weeks ago, where a patient lost their life under that same model, where an anesthesiologist was in the building but wasn't available. And the thing is there are going to be good outcomes and bad outcomes on both sides, whether it's CRNA care, physician care, or otherwise. To delineate that is very difficult. But what's easy to point out is that 36 states in the country have already made this change, and many of those already have better health outcomes in the state of Georgia. Thank you.
Any questions?
I don't have a button.
Well, why don't you use the one down there?
Thank you, Mr. Chairman. I have a question. I don't know if it goes to you or it may go to someone else. If this were to pass and become available, how does that work in the insurance world for what's covered and reasonable and customary? Do they now drop into that you could get your procedure done with just a CRNA? And again, I don't want to open up the thing of if you like the policy or don't like the policy. My question is for somebody that knows insurance, if it can be done with CRNA, that's one less person. And again, not debating that policy at this moment. I know that's under debate, but my question is, if it can be done by state law like that, does that then allow insurance companies to go, okay, in 30009, the reasonable customary cost for this procedure is now this because you can do it with one person less? And if somebody really wanted to have a physician, an anesthesiologist supervise, would that cost fall on the patient? Does anybody know, Mr. Chairman, if this change affects what insurance companies would use as reasonable and customary within the procedures across various, I think I'm doing that right. It may not be by zip code, but it's by region, what regional customer. Would this affect what insurance companies would reimburse?
I think common sense would say yes. Right now, you can already bill for CRNA care with or without a physician anesthesiologist involvement. That wouldn't change. The billing rules, the QZ, QI, AA, none of those things would change. But I would say that as we see the cost of the healthcare going down, the trend is we're already seeing insurance companies come back and say we're going to pay less for these cases.
Okay, if I can follow up, then that means if you're as a patient and you're getting care now with an anesthesiologist involved and you want to continue that, it may cost you more.
It could cost the facilities more. Typically, they receive a subsidy already where these anesthesiologists are involved because currently the billing doesn't outmatch the salaries of anesthesia providers. So they're already billing in the negative.
Is that it? Do we have any other questions from the committee to this gentleman? All right. Thank you so much for being able to come again today. All right. Do we have anyone else that wishes to be heard on this matter? If not, what's the will of the committee? All right. What's the will of the committee? We're in that posture. Representative McDonald.
Make a motion to pass.
We have a motion. Do we have a second to the motion?
Second.
We have a motion and we have a second. All right. Further questions, comments, proposed amendments, or anything else? There is an amendment on the table that's been passed out. Mr. Carpenter.
Yes, sir. Thank you, Chairman. So yeah, we put an amendment on your desk if you want to look it over. But basically, it gets back to the to similar what we voted on last year and outside the metro area. We use this. The best way I could figure to do that was to use the non-attainment zone language out of code. So that would be, it stays the way it would in Bartow, Clayton, Cobb, DeKalb, Fulton, Gwinnett, and Henry County, and then outside of those areas, this new policy of coordination would occur. So you'd be striking lines 22 through 24 on the current LC, and adding in this page here.
Give the committee a couple of seconds to look at this, and while they're looking at it, Representative.
Yeah, so just for clarity, it's status quo in the metro area in those counties that I mentioned, and outside of those counties, the coordination piece would occur.
All right, Representative Chairman Jaspers.
Thank you, Mr. Chairman. Chairman, isn't it true that this would, back as the bill was last year, create a two-tiered system of health care across our state, and in Part B, it really just maintains the similar language that's in the original bill of coordination, that the key word that we've been discussing.
Thank you, Chairman. I think the argument could be made that we already have a two-tiered healthcare system in the state of Georgia. We've spoke about that for the last 8 years that I've been here, that we don't have the services in rural Georgia that we do in Atlanta, and this seeks to remedy that.
All right, number 11. Who is that?
Thank you, Mr. Chairman. I try to stay muted today and not reiterate what I said yesterday, but this is not a rule bill. It's not written as rule. This will impact all 159 counties. And even the amendment will create a two-tier system. Now, if we're going to be serious about health care in Georgia, let's be serious about health care. Let's expand Medicaid. Because I can guarantee you, as a father that's raising 2 doctors, MDs, right now, they're not going to go to rural Georgia after their residency. They want to go to Buckhead. They want to go to places where they can shop, work, live, play, dance, hang out with their friends. Rural Georgia will not provide these young doctors any kind of incentive, right, to go in rural Georgia. In fact, this body, we do not even build rural Georgia. When new companies want to come to Georgia, they want to come in 285. They're not going to rural Georgia. This bill will impact all of Georgia. And so I know I heard a lot of language about this going to help rural Georgia, but this bill does not carry that in spirit. The other point I'm going to say, and we're going to keep talking about qualification, Mr. Chairman, but let's be real. Both of them are very important individuals. The MD and the CRNA. They're very important, but they're not the same. They're not the same. They're not the same in experience, they're not the same in qualification, and they're not the experience of expectation. But this bill, if it goes through, the CEOs of these hospitals are going to look and say, what is our budget? What can we get by? And what is the demand? I just say, ladies and gentlemen, one death is too many. As a retired commander in the Navy, one death is too many. One death. And so we don't even want to roll the die and say, what are our chances? Because we don't want that one death to be one of our loved ones. So I just say, Mr. Chairman, that I'm going to vote against House Bill 251. If we're going to be serious about health care in Georgia, right? We got a deficit of 40,000 nurses. We need 40,000 nurses. But they're not coming. We need OBGYNs. We need more MD specialists. But they're not going to come if we're going to be promoting the wrong piece of legislation. Georgia's ranked number 48 come to health care. Alabama's better than us. Mississippi. So this bill is not going to change our health care landscape. It will worsen it. It will not improve it. And with that, Mr. Chairman, I thank you.
Well, we certainly thank you. Let's see. I've lost my train of thought with that dialogue. Let's see. Well, we do have another country heard from. Ms. Bennett.
Call for the question, Mr. Chair.
All right. We have a call for the previous question. We have a motion, we have a second, and we have an amendment before you. Representative Carpenter, do you have anything else you wish to say about this?
Yeah, maybe for 2 seconds. All right, so something really struck a chord with me when Doc Newton was up there. He said that the physician, when dealing with the anesthesiologist in an emergency situation, bows out to the anesthesiologist, and the anesthesiologist is in control of that situation. To me, this whole bill gets down to the conversation of coordination, because it feels like a turf battle about, if there's an emergency, who's in control. And it's already been said that the anesthesiologist was in control, but for some reason the CRNA shouldn't be in control. So I don't know. I mean, I don't know if that uncovered something. I don't know, but something struck a nerve when he said that. This is more about that situation than everybody's leading us on. So just a thought.
All right. Now we do have a couple of questions. Chairman Cooper.
Thank you, Mr. Chairman. To answer my colleague's question what he mused about, if it's an anesthesia and a surgeon, they are equally trained in their areas of expertise. And So if one of them is deciding the factor, they are basically equals. If when it's with a CRNA, despite how good they are, or so forth, they do not know what the anesthesiologist knows, or even the surgery knows. My thing would be, and somebody keep talking, in these situations, we need a team leader. And the team leader, in my humble explanation, or my humble opinion, should be the person with the most education. And no matter how good a CRNA is, they do not have the education or training or experience that the physician, anesthesiologist, or surgeon. And I think that we always need a team leader. We have a speaker that leads our team. It comes down, he makes the decisions. We need a team leader. Thank you, Mr. Chairman.
Thank you, Chairman Cooper. Number 6.
Yeah, I just want to speak to a few things. A lot of the most compelling testimony we've heard today have really kind of centered around the lack of collaboration that could occur in a medical crew. And I guess what I would say about that is I spend my nights in emergency rooms all over the state of Georgia, and I am humbled and amazed at how well everybody works together to provide care and falls in and does their role. In these situations, I mean, sometimes experience, sometimes it's education, but the collaborative nature of care in these environments is what produces the good outcomes, and lack of collaboration ultimately always results in bad outcomes. So trying to create an authoritarian, a degree or a certificate or a rank, you'll never make sense of how this works. Everybody brings something to the table. Education's important, experience is important, and good teams are able to work together and collaborate and figure out how they're going to bring all this to bear to help our patients. I don't favor a two-tiered system. I mean, ultimately, if the inability to collaborate's the big breakdown, you're going to probably have that worse with less resources. So we certainly don't need anything different in rural Georgia than we need anywhere else. So, I'm in favor of this bill without the amendment. I don't think anybody in rural Georgia has less standards. We also have to, also realize we do all live in the real world. There's a critical shortage of providers in Georgia. We still have to provide health care. We can always say that if somebody had another degree or more training, it would be better, and it is always better, but we got to work with what we have. And I think the organizations that provide health care in the state are pretty good at identifying the resources they have and how they can best provide health care in the state of Georgia for the citizens.
All right, one last one, and then we will move to the previous question. Representative Hawkins. Chairman Hawkins.
Call for the question.
All right, we have a call for the question. All members have had a chance to pontificate and be heard. We have an amendment in front of you. All right, we have a motion. Do we have a second for the amendment? Second. We have a motion and a second. All in favor of the amendment, say aye. Aye. Opposed? No. Show of hands. Everybody in favor, say aye. Raise your hand. Raise your right hand.
1, 2, 3, 4, 5, 6, 7, 4.
7, 4. Opposed?
1, 2, 3, 4, 5, 6, 7, 8, 9.
And the amendment fails. To the body of the bill. If there's no other amendments, all in favor say aye. Aye. Opposed? No. Show of hands. All in favor, raise your hand.
1, 2, 3, 4, 5, 6, 4.
6, 4. All opposed?
1, 2, 3, 4, 5, 6, 7, 8, 9.
And the bill fails. Now, I want to make a couple of comments before everybody starts getting out of here on this. This has been an interesting area for this committee to work into, but I think it's something that we have systemic problems in our state when it comes to health care. Some of folks want to pit the metros versus the rurals, and I know it's a fact of life, but for those folks who want to come to Buckhead and dance and jolly and all of that, there are also those folks who live in rural Georgia who enjoy that lifestyle. And I submit to you that the folks of rural Georgia deserve the same care and treatment in their hospitals. We deal with my hospital up in Livonia. They deal with having to scrounge around for OBGYN, anesthesiologist. Now, I know that it's been my observations over the years when it comes to these type of bills in the healthcare community, it's a turf war. Who's got what and who wants what? And it's always about a turf war, and somewhere down deep it's about money. But I would submit to those of you who are the policymakers out there, y'all need to put your heads together. You need to put your egos aside and start coming up with some real ideas that's going to help everybody in the state, because not everybody wants to live in Fulton County. Not everybody wants to live in Cobb County. You know, believe it or not, we have a dandy good lake and a golf course up in Hart County and up in that part of the world. A lot of people have migrated up there. There's some reason, God help me, my real estate practice, that we're getting all these folks out of California that want to locate up there. And if you're talking about misery, then I can tell you what misery is. So that being said, that's my pontification about the healthcare system. There's something that's got to be done. Everybody wants good health care. We want the professionals, but maybe there needs to be another look. I remember passing a nursing bill last year that was pretty simple about placards and handicap placards and such, just minor stuff, and I dealt with the medical profession. Well, here we are 12 months after that bill passed, and the composite board still hadn't set rule and regs. So if I sound like I don't particularly care about the influence of MAG, hell no, I don't. So that's what I have to say about some of this. It's time that we move forward and try to do something for all of Georgia. That's all I've got to say, and this meeting is now adjourned.